So the presentation was presented as moving transplant from inpatient to outpatient, since reimbursement is not necessarily the best, and patients have to get specific diagnosis codes inpatient. Outpatient, you can bill items separately per drug, per chair time, per facility fee. So the potential to be able to get better reimbursement is there. We've done outpatient transplant for quite some time at the Seattle Cancer Care Alliance. And so this talk, while it started off as reimbursement and insurance, has kind of moved towards a talk about how to practice outpatient transplant, including the role of the pharmacist, but also the clinical operations side of things too, since there's a lot of non-pharmacist items to consider, since not every place performs outpatient transplants. Our outpatient transplants, we do about 60% allogeneic transplants in general, inpatient and outpatient. Outpatient comprises about 35% of our transplants, basically on average per year. Most of those are auto transplants, 65% actually, and we have different types of donors that we've talked about. But actually a paper I'm talking about is a paper by Clemens and colleagues that basically clarifies the role of the transplant pharmacist. There's specific FACT criteria that centers, if they want to be accredited as a transplant center, have to follow, and it's only recently that pharmacists have had more delineated and specific criteria in terms of their education and what services they need to be providing. So I'm speaking on that a little bit and then relating that to how we practice at our center. There's data smattered about in terms of studies involving cost of living close to a center, because for outpatient transplant, most of the data shows that any place performing it has patients live within a certain mile range or minute drive from the center, including ours. And there's some data about patient safety as well, since people wonder about how safe is it to perform outpatient transplants.